Hello, hello. Good afternoon or good evening, wherever you're tuning in from across Canada or abroad. We would like to welcome you to another edition of our NSWOC and WOCC Institute Continuing Education webinar series. As many of you may know, my favorite little icebreaker game is for you to click on that chat button in your Zoom toolbar and just let us know where you're tuning in from today. My name's Troy, and I'm the Director of Operations for Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm tuning in from Ottawa, Ontario, and we have an amazing guest with us today who we'll introduce in just a moment. Before we get there, I just want to thank Smith+Nephew for being able to put on this wonderful education again today. We really appreciate it. We're going to be talking about case review, sNPWT application, and best practices in just a moment. But before we get there, I just want to go over a couple housekeeping items. Firstly, we're going to be having a Q&A portion at the end of this presentation. So if you can click on that Q&A toolbar when you do have a question and pop your questions in there, that'll indicate to Amanda and myself that you have one, and we'll try to get to as many as we can at the end of the presentation. It is being recorded, so you'll be able to watch this after the fact as well, or if you need to share with a colleague to go take a look at after, that's just fine. And everyone who's attending live today will be receiving a certificate of attendance. I'll remind everyone, of course, we will have a survey that will pop up at the end of the webinar. Please make sure to fill that out before proceeding further. So without further ado, I'm so excited to be introducing our guest presenter today, Amanda Loney, who earned a Bachelor of Science in Nursing from the University of Western Ontario and acquired her WOCN designation from Albany Medical Center in New York, and has also completed the IIWCC at the University of Toronto. As a community-based nurse and educator for 25 years, Amanda has spent the last 20 years specializing in the areas of wound, ostomy, and continence, and is currently a certified nurse specialized in wound, ostomy, and continence. In her role with Bayshore Home Care Solutions, as well as in her private practice, Amanda is known as a passionate educator and consultant, as well as for her extensive clinical knowledge. Most recently, she has keynoted at national conferences and is published in the International Wound Journal. So without further ado, I'm so excited to be passing over the mic and the slides to Amanda. Thank you so much, Amanda.
Thanks, Troy. So good evening, everybody. I'm glad that we have such a great turnout on a nice evening like this. So thank you very much for coming out. And let's get started. So my goal is to try and kind of answer some of your questions around single-use or disposable negative pressure wound therapy. And this one is on the PICO. Disclosure, I am being compensated for talking with you this evening. Okay, so learning objectives: to review clinical evidence for our PICO, so our disposable negative pressure or single use, and best practice recommendations to recognize advanced applications with PICO for appropriate wounds, and to develop strategies to incorporate the techniques in advanced application. So let's get started. So I don't think everybody that's on our talk this evening and that's joining us now know just how much wounds cause for wound care cost across Canada. And very specifically, we now have we're in the past, we're drawing from American numbers, but we're looking at $1.5 billion direct costs. And this is for Ontario for wounds. So not only does this have a cost financially to us and to all of our patients, but also it has a cost more for the patient in general through all different sorts of issues with our patients: anxiety around their wounds, stress, the pain associated with our chronic wounds that aren't healing, social isolation, depression, sleep deprivation, body image, odor, exudate. So all these things can actually lead, and not only do they slow down our wound healing, but they can definitely cause chronic wounds to prevent them from healing. So how can we help our patients heal up quicker to deal with these not only financial stress, but kind of social stresses that we get as well? So I just want a little icebreaker here. I want to kind of know the area of practice that we're dealing with. So those of you who are joining me, if you have the polling question there, if you can kind of click on and tell me where your area of practice is. Is it acute care, community care? Is it community care in a clinic setting, long-term care, administrative role, or other? So if you can go ahead and click there, that would be great so we can see.
And you should be able to see your results on screen there.
Okay, we can. So we have a lot of community care in the home care setting. So as you know, that's kind of my main background. I do a lot of community care in a clinic setting as well, and long-term care. So it looks like kind of the people that are joining us are kind of in my realm. So that is great. And let's move on. Okay, so what areas do you find challenging to apply negative pressure wound therapy, and specifically disposable or single use like the PICO? So do you guys find it difficult for the coccyx, under an ostomy appliance, the forefoot, the breast? What areas would you find to be the kind of the most challenging? So go ahead and click there, and hopefully we can address some of those issues.
Perfect. And you should see the results there. And I apologize, I missed the panis on the poll question there. So I apologize to
Okay.
those who wanted to click that response.
That could have been under the other part. Okay, so we have a lot that's saying the coccyx underneath an ostomy appliance. Yes, that's always very challenging, the forefoot and a little bit in the breast area there. So the majorities are saying the coccyx, and I probably think that that's because that's the majority of where you people have actually tried to apply it and had some difficulty. Under an ostomy appliance, that's it's definitely can be challenging, and it's not very done as often. So let's take a look and keep going. Okay, so when we're looking at the PICO, so this is what we're talking about. So let's just take a look at what the family of the PICO involves. So you have your PICO 7, that was your traditional one. So this device is good for 7 days. And now we have the PICO 7Y. So this one, and I'm going to be honest, I haven't actually used this one. This one actually has a Y connector like it would in your typical negative pressure, where you're connecting 2 separate wounds. And you can connect it with that one. And then you have your new PICO 14, and that one is good for 14 days. So if you know that you're having a patient that's going to be on it for a substantially longer time, that one makes sense. But they all work the exact same way. Okay, they just have different lengths of stay. So when we're looking at the performance and portability, so we have very simple application. We're going to show you kind of just how simple this is. It varies in size with dressing up to 7-day wear time when you're looking at that. So you have a positive outcomes. It helps patients with open wounds of low to moderate exudate and levels, especially with early intervention. And we're going to show some of the studies that kind of that support that. And now we're going to look at patient friendly. And I think this is one of the biggest reasons why I jump to trying to use disposable or single use negative pressure, is because it is patient friendly. And the majority of you are dealing in outpatient and community settings. And so you want to make sure that your family and everything feel comfortable using that when a nurse isn't around. Lightweight, it's discreet, portable for greater patient freedom. And then cost effective. So majority of us don't actually kind of get that bill at the end of the day and have to deal with that. But for those higher up, it makes sense. So if you're trying to actually look at making a call for this, cost effective is definitely something that you always want to think about. Okay. So I'm going to actually just get that there. Okay, so efficiency through the design. So PICO 7 designed full addressing those full indicators. So these are your lights on your PICO 7 when you're looking at that. You have the okay green light, and when that's green, everything is good to go. You have an indicator when you have a leak. You have an indicator when you have a full dressing, and you have an indicator when the battery is. That's it. So there's no other scrolling through all your screen to see what's going on and what the issue is. It's very, very simple of how the canister or the little device works. Okay, so 50% less dressing changes with the PICO than you have with your traditional. And typically the PICO can be worn anywhere between 1 to 7 days at one given shot there. Okay. So how does it actually work? So typically in your traditional negative pressure, that the negative pressure sucks that up and brings all the fluid into a canister, and that the person carries around this big device, and the canister is actually what collects all the fluid. This actually works by the foam in itself is what actually absorbs that fluid. So you have the airlock technology layer. It distributes the negative pressure across the whole area of surface. You have a super absorbent core, which absorbs that fluid, and then you have the top layer. And this is a very high moisture transmission rate. And this is where the moisture will evaporate out the top. So when you're thinking about putting this on and you're putting on different places, the amount of fluid that it can hold and that it can deal with it can depend on where you're putting that. So if you're putting that under someone's bottom and they're sitting all day, they're not going to have as high as moisture transmission rate as if it's on somebody's abdomen and it's kind of open on a loose shirt or on somebody's, leg or something along those lines, or if it's on a foot and you can tell them to take off their sock and then it can evaporate and it can manage more fluid that way. And then it has this silicone adhesive border, which is very gentle to be using. Okay, so absorption, 20%, approximately 20% of the fluid is locked inside the dressing away from the skin. And then 80%, like we talked about, is actually managed through evaporation. Okay, and again, that can vary depending on where your dressings are, but that typically is how it's managed. It has a unique 4-layer multifunctional dressing design, which we just discussed. Okay, so this is what it kind of looks like, the box that it comes in. You see it comes in a nice little box. That's everything in that box. So you have your little machine and your dressings and the batteries and everything goes there. And then you have all your different dressing sizes that come with it as well. Okay, you can buy your dressings separately, multi-pack with 5 dressings. So if you are changing somebody's dressing more frequently, like every 2 or every 3 days, you may need more than the 2 dressings that come in the box. So you can buy your dressings separately. Okay, so now we're going to get on to the fun part, the evidence and the supporting case studies around using your PICO disposable negative dressing. So what makes you think twice about using single-use negative pressure therapy? Okay, so polling question, let's go. What makes you think twice? Is the depth of the wound greater than 2 centimeters? You're like, no, wouldn't do that. Or the complexity of application. So where do you think that you can't maintain that seal? Moderate to large draining, that you wouldn't use it, or position of the wound, unlikely to achieve the seal, or the cost of single-use negative pressure. So go ahead and put your vote in there.
Perfect, and you should see your results now.
Okay, so we have the depth of the wound. We have a couple of people saying that they wouldn't do it for greater than 2 centimeters. The complexity of application, oh, I'm glad that's not holding you guys back. So the drainage seems to be the biggest one. 44% say that they would think twice about using it related to the drainage, and then the position of the wound, the likelihood of achieving a seal. And then the small portion also saying the cost of disposable negative pressure. Okay, so good to know. Let's see if we can kind of shed some light on those topics. Okay, so here we go. So here's our first case study. So we have a perineal wound. This is the second attempt at a closure after initial APR failed to close, leaving a 10-centimeter tunnel for greater than a year. So this young woman had a tunnel and it was a good 10 centimeters long and she had it over a year. We couldn't get her closed. So they reopened her up. She has a history of ulcerative colitis, a very high risk for dehiscence. So what we were thinking about here before she even went in, we were looking at thinking about, should we be thinking about using disposable negative pressure for this lady? So some of the reasons why I would think about using that. Okay, so all the benefits of negative pressure over a wider area. That's why there's a difference between your traditional negative pressure and your disposable. Your disposable actually gives you that negative pressure over the whole entire area that the dressing is sitting on. And there's definitely benefits to that. So you have the benefit of the dressing of your protecting from external contamination. You have that with both. It promotes granular tissue. It increases the blood flow. So not only does it just increase the blood flow right to the area where you would typically put negative pressure, your black foam, but it increases the blood flow now farther out. It reduces the edema farther out. And it removes the fluid, wound fluid, and the tissue from the area. So the zone of injury when you have surgery is actually much farther apart than the actual incision line is. So if we're able to put that negative pressure farther out, we get the benefits of actually getting rid of that edema there and bolstering that wound closed. So compared with standard care, PICO, single-use negative pressure, helps to significantly reduce the odds of surgical site infection, necrosis, seroma, and dehiscence in patients with closed surgical incisions and reduces the hospital length of stay. So there is lots of studies out there. I'm not going to go through all the studies but actually showing that putting the PICO on your single-use negative pressure is going to actually help decrease the risk of dehiscence and infection. So when we already have a lady that has a really high risk of dehiscence, the last thing I wanted to do is dehisce this wound. So we agreed that we would put this on right away. So I sent her one to the surgical site. We talked to our surgeon before we actually did this, and he did the surgery, and we got her on negative pressure, single-use negative pressure PICO right away. So you can see how we kind of put this on her. It kind of went on pretty nice. So when you're putting it on the bum area, you really want to try and spread that buttocks really well so that that PICO goes on. And I'll show you kind of how some tricks on how I applied that in a couple of slides. Okay. So despite all our efforts, the incision line did dehisce approximately 2 weeks after surgery. So I kept the PICO on her. We started to see a little bit kind of more drainage, and she did get some dehiscence. I didn't actually show you the picture here of the dehiscence, but I kind of showed you on the lines where we had this. So we had it open up approximately 3 centimeter width at the front and at the back, and then we had a depth of about 5.5 centimeters. 3 centimeters to the top end of the incision line with a depth of 13 centimeters. The bottom one is a wider and draining moderate to large purulent drainage. Okay. So when you're looking at negative pressure, when you have disposable negative pressure, when you have wounds that are 2 centimeters or less, you typically don't need to use any type of packing for these wounds. So when we first put that on her, we didn't need to use any type of packing for her. But now that we have, if you have some depth to it, and we talked that we had tunneling, you would absolutely need to do that. So I think typically we've all thought of disposable negative pressure is to be used with 2 centimeters or shallow wounds. And I think this is when it first came out. That was kind of like the go-to dressing for those shallow wounds. We put those on 2 centimeters or less. But now we actually know that there are studies that you can use these for wounds that are deeper. So they did some studies and they said definitely 4.5 centimeters, we know we're still getting those pressures. Okay, so after we know this, so we know we can deal with deeper wounds, would you consider using traditional negative pressure? Okay, so the Renaissance edge with a black foam. So you think about, you have those openings now. Would you use the Renaissance edge with Acticoat wick to the base? Would you use the black foam filler with the PICO? Would you use Acticoat wick to the tunnels with the PICO, conventional dressing, or Durafiber AG rope and absorbent topper? Okay, so let's see, what would you use? Would you use, basically, would you use your traditional? Would you use your PICO, or would you go back to your conventional dressing? So pick and choose there and see what you would do. Okay.
Just wait a couple more seconds. There we go. You should be able to see the results on screen now.
Okay, so we have about 8% saying traditional negative pressure, so like the edge with a black foam. So you're going to put those in the 2 centimeters base, and then you're wicking to the base of the tunnel. We have 10% saying the traditional, the edge with Acticoat wicking in there. Okay, black foam filler with the PICO. Okay, 29%. Acticoat wick to the tunnels with the PICO, 40%. And then you have conventional dressings, and then you have like a conventional dressing, your Durafiber rope with an absorbent topper, and then others. Okay, so let's see what we got here. I'm gonna go on here. Sorry, there's a bit of a delay going here. There we go. Okay, so here's the actual wound. So you can see the wound here. This is like, you can definitely see the top wound. And you can see that I'm kind of getting ready to put negative pressure on there. I used some stoma. This one looks like a ring. Sometimes I'll use a paste and or a strip paste. The ring tends to have a little bit more firmness to it. So for deep ones, I would use the ring. And then I use the gel sheet on either side, and I would do that to help protect the peri wound. Okay, and here you can see that I actually wicked her with a piece of black foam. And I did this because I actually think the black foam is the best thing to actually wick away fluid really quite quickly, rather than kind of just pull it or keeping a wound open. It is the best thing that you can do to help get rid of fluid, to make fluid move. Okay, so this is what I used for her. And did I use traditional? I did. So I did use traditional here because she did have quite a bit of drainage, and she had a 13 centimeter tunnel there. So we did go with the traditional here at this time. And I think we actually had a little bit easier of an application with this. So I used the AMD Curlex just to bridge the two tunneling, to wick that across, and it actually bolstered the rest of the incision line still. Not quite as far out as what you would get with the disposable, the PICO, but it still did that, and that's why I continued to kind of address that whole incision line, because I was really hoping to prevent that whole thing from kind of opening up. And when I'm putting the black foam in, I try not to get it to the full base. I would normally pull it back a few centimeters to hopefully get that to close up from the inside out. Okay, and when dealing with the soft port, you don't actually have to track that far away. I just tracked it a little bit because it's harder to put right into the crease. Okay, so reassess, reassess, reassess. We did this for a little bit. I didn't think we were getting anywhere. I talked to the surgeon. I'm like, I do not want to have this lady with that tunnel. So she ended up with a tunnel right in the exact same spot that she did before. I'm like, let's just open it up and give me a full open wound and let me heal it that way. So that's exactly what the surgeon did. We didn't wait too long for this. So we opened her right up again, and then we used the black foam and the traditional negative pressure right to the wound bed. And you can see that I got access to the full wound bed right there. Okay. And again, when putting, whether using traditional and or the disposable, the PICO, I did use the paste on the creases there. And I did use the gel sheet, and I really like using that gel sheet, and that actually helps protect that peri wound. And I don't have to be so specific when I'm dealing with black foam not to make that touch onto the peri wound, so that I don't cause any kind of suction injury there. Now, when we're looking this, so she was healing really nicely. So now we actually have the deep tunnel kind of gone. You can see in that middle picture, she still has a little tiny tunnel there. That was only about like 2 centimeters or so. And so I did address that with the black foam again, because I think the black foam gives me kind of like the wicking away of the fluid, and I didn't want anything kind of pocketing in there. You can see how I put the paste strips there to help get the seal, and a little bit of the AMD Curlex on top of the rest of the wound. So what would we do here? Would we go traditional, or would we use the PICO? So what are your options here? You could do either or here. Okay, so when we're looking at PICO now, because before typically you wouldn't use that for large wounds, but and this is the kind of the rule of thumb is that if you can manage your drainage, so if you, when you lift that PICO off, if there's not pooling of fluid in that wound bed, then and it's not leaking out of your dressing. So you can contain your fluid within your dressing, and you're not getting pooling of fluid underneath the PICO, then you can use it. So as long as you can actually get the wound underneath the PICO dressing, as long as you can manage the fluid that you don't get pooling under the dressing, then you're pretty much good to go with using that. Now there are little kind of devices that you can use. This is kind of like the simplest form, the exudate level. If you've got really high, obviously, you know, if you can't manage it within your dressing, then don't go for your PICO. And if it can fit underneath your, if it can fit underneath your dressing, then you're good to go. Okay. So there was a whole bunch of very smart people that decided that if you needed a kind of a helper, that there are helpers out there that you can use, and this will kind of guide you the one negative pressure clinical decision tree to decide whether you want to use your traditional, the edge, or your PICO dressing. So you can decide that. And just to let you know that we did have a really happy ending with her. Once we actually opened her up, she healed very nicely. Here you can just see her opening was 1 by 0.2, and she went on. We just continued to wick that with a little bit of Acticoat Flex. And believe it or not, this lady actually was doing her own dressing changes. So she would actually wick herself. She was kind of flexible. So she was able to do her own dressing changes. And I know that a lot of you work in the community setting, and I really encourage you to not discount your patients and or family from helping out, because we know statistically and through studies that those patients that actually do their own dressings or partake in those dressing changes, even part of it, they have like a sense of ownership and they do better. So don't write off. You know what? I always put it out there. Do you think you can do this? Show me if you can do it. I'll show you what you can do. And if you get your patient buy-in, then I think it's definitely something that you want to try and pursue. So our next one, pilonidals. Everybody gets these pilonidal sinuses. We see these very commonly. And I think over the years, traditionally, we used to see surgeons really go in there and just decimate people's bottoms. They would just cut them out and leave these great big, huge, massive kind of craters. But now we're seeing them doing them much more conservatively, and they're just going in kind of addressing the tunnels. And so this is kind of what is considered best practice now for dealing with pilonidals. So you can see here my picture on the far left there. You can actually see where we had like the little tunnels all kind of connecting. And so what I did here was I wicked these with Acticoat. And that's to kind of keep that tunnel open, but allow for the drainage to kind of drain out until it kind of heals from the bottom up. And then I use the dressing to cover the whole thing. And you can see here to maintain a seal in that bottom corner of the dressing there, you can actually see where I use a little bit of paste to make sure that I maintain that seal right in the crease of the bottom. Okay, so this patient used to come in and say that she's always wearing her orthotics and her shoe with every step she takes. So I always like enjoy, you know, when people are saying that they're wearing their offloading device or they're wearing their, you know, their proper orthotic, is to take a really good look at it. So if someone's walking around in their offloading device, it's going to look worn. If they're walking around in their orthotic, it's going to look kind of worn. So this little lady, she used to always walk around in her slippers. She swore to me that she never did, but she would come in and her dressing would be like totally sheared off. So I always found this kind of, and to boot, it was like sheared off so much that she maintained a seal. So she said, look, it's green, it's green. She actually sheared a dressing off. She maintained her seal, but it wasn't actually on the wound at all. So how can we help prevent that from happening? And again, the gel sheet to aid in adhesion. So you can do that. Putting the gel sheet around does kind of give it a little bit better grip and stick. Often too, you want to try and put the pad up even higher than what I did here sometimes so that it's on the top side of the ball so it doesn't catch the edge of the dressing and kind of rip off. And that's where I would actually use sometimes for some patients even paste, strip paste, like ostomy strip paste into the creases of the toes. I find the tube paste not great for this type of thing, but the strip paste is great for between the toes. And just so that you're wondering why the wound bed is gray there, you can see in the right-hand side there that she does have some kind of hypergranulation. I treated that. I put some Acticoat on, and then we reapplied the negative pressure. She did do very well. And the reason why I actually put this on this lady was she had this wound for years, and we had no improvement. We went through the whole gamut of dressings for her and no improvement. And I'm happy to say that she actually showed some significant improvement with using the PICO dressing, despite the fact that she would shear it off from time to time. This was the only dressing that we actually showed her, and she's almost closed at this time. And that was probably about 12 weeks of using the negative pressure where we were getting nowhere without it. Okay. So another case study. So this lady had a left BKA, and the patient reports that they also developed following some hip surgery and some weight gain. So she had this right behind the knee, and you can see that there's lots of kind of scar tissue there because she had a skin graft there. So the blood flow to that's probably not great. She also had some pressure there still from her prosthetic that she was wearing. So she was doing her own dressings for a while. She had the drainage as moderate to large serous with very slight purulence, and she wasn't getting anywhere with that. So again, we used, so if you actually look, we go back, so I don't have the dates there, but she actually was doing her dressings. Oh, I do. So 4 months she was doing her dressings. We tried all advanced wound care dressings out there that are available. So, and we actually didn't get anywhere. We actually had an increase by 23% over that 4-month period, despite the fact that we were telling her to offload her prosthesis and to do the wound care. So you can see her wound looks a little bit better. It's not quite so pale, but again, and the edges aren't quite so cliff-like, but we weren't getting any healing with her. So everybody's kind of seen the wound bed preparation, kind of going through that. Person with a chronic wound, you have to identify and treat the cause. So we're thinking the cause there was a lot of her pressure. So we did send her for her prosthetic to be redone. A couple times we did that. So she did have the ability to heal. We did do all best practice local wound care. And we did some debridement, we treated inflammation, we had perfect moisture balance for her. So now we're going to move on and we're going to look at treating the edge effect. And this is where you're going to get into your advanced modalities, and such as using your PICO disposable negative pressure. So we cleansed the wound bed there. We did use the hypochlorous acid soak. We applied the Promogran and Acticoat for her. And then we stopped the Acticoat. We just switched to the Prisma, and we continued applying the Acticoat, and we used a 15 by 15 here. Sometimes we changed up the type we used, and we changed the dressing twice a week. And at one point we actually left her, as she went on, as long as I knew she was maintaining the seal, up to 7 days. So let's take a look at this. 17 days with PICO, the wound has decreased by 31%. So I think I said like 4 months or so, we had no improvement. 17 days, we had 31%. 6 weeks with PICO, the wound had decreased by 73%. And you can see the photos there, some significant improvement. January 29th, February 15th, March the 11th. And you can see that things are much, much improved here. We're getting the epithelialization happening. So this is what it kind of, it looked like, you know, not a bad spot to put this, but right in the crease, if you think in the back of your knee bend there, and the prosthesis hit. So she had some kind of deep creases there, and I left the plastic on the adhesive gel patch to show you where I would use that. And I would use that in those deep creases. And I used a double layer at one point on the one side there where you see that blue arrow. And you can see how you're doing that. And we're managing our draining, our exudate very well there. Okay, so it increases the blood flow to the area. It encourages the epithelial tissue to grow. And I'm sure that this is why we actually saw some improvement with her wound with this, because now we're actually causing that increased blood flow all around the area, which I think that she was definitely having an issue with the circulation in the graft site there. Okay, so you can see after the effects of PICO, March the 25th, you can see how nice it is 2 weeks later. So we did actually stop the PICO dressing, and we continue to have some really significant, the wound had decreased by 51% in surface area after stopping the PICO. So we went back to kind of conventional wound care that we would even use before, where we were getting nowhere. But now after stopping the PICO, we can see that she continued to have success. So PICO does kickstart healing trajectory, and we can see that even after you stop, they show statistically that you actually get continued healing happening with that. So I think it's also very important to make sure that, because there is some, and we'll talk about this in a bit, some kind of up in the air as to when do you stop using it. And so always reassess, right? Because you can always restart it again if you need to. Okay. So here's just kind of an easy application on someone's forefoot there that's missing all the toes. Everything went on very nicely there. You can see just easy application. But then the one time I put it on, and then we kind of put it on a little bit weird. We actually had a 15 by 15 dressing, which didn't go on quite so nice. But you can see here how we actually saved the dressing by using a little bit of the paste on those creases. And then you just put the drape over top, and then you maintain your seal that way. Okay, so think about that when you're looking at trying to put on your PICO on those more challenging positions. So our case study here, we had a gentleman come in, 55-year young male. Patient refused amputation, so he was in hospital. He was kind of an uncontrolled, untreated diabetic at this point. He was a farmer, kind of didn't really kind of take care of his feet. And you can see that he ended up going into the hospital. They wanted to cut off his foot, and this is what he looked like when they were there. Okay. So 1 week following good wound hygiene. So like massive difference there. So this is what he came out with hospital with. This is after good wound hygiene. So we didn't do anything else except really clean that foot up, scrub it, do a wash soak, and control the moisture here. So that's what we were really looking at doing here differently. And you can already see a significant difference. So we did wait a significant amount of time before I kind of got the okay to really be aggressive with debriding. So we waited 7 months following the initial assessment, was given the green light for aggressive sharp debridement. So all that kind of black eschar was taken off of his heel. So he came to me following the surgical debridement, you can see on the left-hand side, and then following conservative sharp, this is kind of what it looked like after I kind of got at it. And then we initiated traditional negative pressure. And again, this is because the wound is draining quite a bit at this time. So you can see March 7th, 6 weeks with traditional edge negative pressure. And this is how we actually applied that. So if you don't want to take the time of making that black foam exactly to fit to the wound edges, then you can picture frame around the wound edges, either with a light hydrocolloid or the drape. And then we put Acticoat across, and I used the Acticoat across because he did have kind of a smelly wound there, and it was looking a little bit pale at that time. And then we went ahead, and this is a little trick that you can do. I did put the drape just to hold that black foam in place when I'm putting the drape over top. So if you don't have multiple hands and the person's foot sitting up, often kind of taping the black foam in place helps you with getting the securement of that. So transitioning from the edge, traditional negative pressure, to the PICO. So why would you do that? So you would do that, it's much easier to apply. So taking a look at this, so it's much easier to apply, and we know that it costs much less. And we also know that it actually has clinical evidence is out there now. So it's not just about the cost and easy application, but we actually know clinically studies show that patients actually do better, diabetic feet and lower legs do better with the PICO disposable negative pressure than they do with traditional negative pressure. We actually have better healing times. So you can see here, this is the first time I applied it. I was a little leery as to whether I was going to be able to manage my exudate, because originally he was filling those canisters, and when the canisters, he wasn't filling those that much. I thought, okay, let's give it a try. So I put on the PICO, and then he sent me a picture of his wound saying, and this was actually like on the Monday, and I put the PICO in on the Thursday. So he was managing his drainage very, very well. So that's how I know I can make that transition. Okay. So this is basically kind of showing the evidence, what I just said about how PICO does better with your venous leg ulcers and your diabetic feet ulcers than the traditional does. So they actually did a study about this, and they showed in the Kirshner study that the wound area, you have greater reduction in the wound area, the depth actually came up, and you had wound closures quicker with using that. So not to mention that you actually had much greater patient satisfaction with PICO than you do with traditional negative pressure. And I think that kind of goes without saying. You're not carrying around a machine, the ease of application, you don't have, the complexity of it happening. If they actually lose a seal, that's okay. You still have an advanced dressing on their wound, so you don't have to take down that dressing like you would with traditional negative pressure after a few hours, because the dressing itself is what is absorbing your drainage and managing your drainage. So you had greater overall satisfaction and better outcomes with using the PICO. and you save money financially. Okay, so you can see 31% more expected closure with ulcers with the PICO versus your traditional negative pressure. So this was a case study. Again, this is a peristomal ulcer. So we talked about putting negative pressure underneath an ostomy appliance. This was a lady who came in and she had what I thought was PG. She did go in and have numerous biopsies, and they tried to tell her that they didn't think it was PG. Every time they biopsied, the wound got bigger. So she had a 61% increase in surface area over the past month. The ulcer had been biopsied twice. She had a temporary stoma, and she needed this to close before they would reverse it. So what are we thinking about when we're looking at this? What are the issues around healing? How do we address them? So we have the ongoing trauma of actually the appliance and taking off the appliance. We have the leaking of the stool into the wound bed. We had the biopsies that they kept doing. And then we had infection that she was getting related to the leaking of the stool in there, and the fact that she's got a very large wound there. So, and we had an inflammatory reaction, and the stress that she was going with her ostomy constantly leaking, and the severe pain that she was getting there too. So why not traditional negative pressure? How will a single-use negative pressure PICO address the issue? So why not use traditional there? And I'll tell you why I wouldn't use traditional there. So PICO demonstrates greater reduction in wound area than the traditional similar, okay, in randomized controlled studies. So when we're looking at using the PICO, we actually had greater reduction in the wound area. So why not go with one that's going to give you the better results? We have the reduction in the wound area observed with PICO can be attributed to accelerated re-epithelialization, not contracture. So typically when you put on negative pressure wound therapy, the wound actually kind of contracts and gets smaller. It gets sucked in. But actually with PICO, you see the improvement in re-epithelialization. So you see your skin coming in. So it's getting smaller because the skin is actually coming in as well. Okay, so when you're doing those. So we had reduced wound bed inflammation when you're using your PICO. So when you're dealing with somebody with PG, you definitely want reduced wound bed inflammation. So using, putting black foam in this type of wound wouldn't be my go-to. Again, you want to look at trying to reduce the inflammation for this type of person, okay? So one of the other issues too that we know that can cause inflammation in a wound bed when you're using either types of negative pressure is that when you're using your wound contact layers, you got to make sure that you're thinking about not leaving any debris behind in the wound. So when you're cutting those black foam, make sure that you cut away from the wound. Make sure that when you're done cutting that you kind of scrape the foam if you're using that, so any loose debris falls off of it and is not left in the wound bed, because that can cause an inflammatory response. And I've seen this happen a couple times where a wound will totally close up and then all of a sudden it blows open again. And then I can see at the bottom that there's these flecks of black foam and stuff like that that's been left in the dressing. So be very left in the wound bed. So be very careful when you're putting in those using contact layers that you don't leave anything behind. Okay, so this is how I managed her. So I did use an interface to kind of bring this up, and why I used the negative pressure versus any other type of dressing is that I wanted to maintain her seal. So how am I going to maintain her ostomy seal? I need to address the actual drainage, and I need the flat surface to apply her ostomy product on her ostomy wafer. So this is how we actually addressed it. And when you're looking at whether you're going to a PICO wound or not PICO wound, you have to be thinking about whether the dressing, when you put it on and it collapses, is going to come in contact with the full wound bed, or whether you're going to have a gap there. And although this wasn't an extremely deep wound, it did have a couple centimeters of depth to it. So I actually used 2 layers of foam interface underneath it to address that depth. But even if it could go underneath that, I didn't want a big dip in it because I needed to put her appliance on. So I wanted that negative pressure to be flat. I wanted the top dressing, the PICO, to be flat to be able to apply it. So when you're actually putting in your you're dressing your foam filler, whatever it may be, don't overstuff your wounds, okay? That's really important no matter what type of dressing you do. Don't overfill your wounds. Okay, so you can see here how I use the application of PICO under the ostomy appliance. So I cut a little bit of the border away, and I used a strip paste around it. I used a ring around the actual appliance, and then I put it on this way. So she was going from changing her ostomy appliance numerous times a day to actually lasting like 3 days or more. So you can see that we had the wound decreased by 56% in surface area, and it decreased in 1.6 centimeters in depth, and that was 20 days with the PICO. So she had been increasing, and now we actually got her to decrease, okay? So that was, the wound had decreased by 61% in surface area over 7 days in between September the 14th and the 21st. So we were seeing significant improvement. Okay, so how did the PICO aid in healing for her? We had lack of trauma, so we are getting a good seal. We had undisturbed healing, and we know how important undisturbed healing is. So we're not decreasing our wound temperatures. We're maintaining it. We're not creating bacterial to get in there, so she didn't have any more infections happening there. So aid in maintaining a seal, less wound surface damage each time that we actually did that, accelerated re-epithelialization. And again, that's just not wound contracture, but that's actually epithelialization coming in, and reduce wound bed inflammation. We manage her drainage, and we decrease the risk of infection. So you can just see how nicely that actually goes. Okay, so polling question. When do you stop negative pressure wound therapy? Okay, so when do you stop? Gut feeling, do you just go by gut feeling, not by like a certain percentage? Wound reduction of less than 5% at week 2 or less than 7%, 7.5% at week 3. Wound reduced in area by greater than 40% per week. Wound area reduction of 10% to 40% per week. Answers 2, 3, and 4. So when would you actually look at stopping negative pressure? So log in your answers there.
Awesome, and you should be able to see your results on screen now.
Okay, so we have answers 2, 3, and 4 were the greatest. So 38% said that. Area of reduction by 10% to 40% in per week. And then we have the little bit of everything after that. But most of you are saying kind of all of the above. Okay, so here's what we actually kind of go. So if you need kind of a guideline to go, moderate, we would call a moderate responder. So the wound area reduction of 10 to 40% per week, that's actually kind of, you're looking good. Okay, so you can continue. That's something that's it's doing well, 10 to 40%. They're saying a good responder. So you're getting reduction area by 40% per week. So, you know, you're healing really fast. You can stop your PICO therapy. And then you get a non-responder. So stop PICO therapy if you're getting less than 5 to less than 7.5 or 10% in 4 weeks. Now, I think these are really big guidelines, because if I'm not actually getting any healing for somebody, so if I, let's say, have a diabetic foot and I went, you know, numerous months with getting no percentage of healing, and now I'm getting, you know, 7.5% healing every 3 weeks, I'm going to consider that a success. But if I'm, you know, and again, for my lady, why I would stop for her is whether I can determine whether I'm actually going to maintain my ostomy seal. So that was kind of my thought process. Am I going to maintain my seal if I take her off the negative pressure? So the last thing I want to do is her to go the other way around. So you can actually look at October the 1st, I stopped the PICO because I actually thought at this point I would maintain my seal for her. And she did maintain her seal, not as long. She did maintain it. And you can take a look here. 1 week without the PICO, I was getting a little worried because she had another breakdown. She wasn't maintaining her seal quite as good. So we kind of kept a close eye on her. I didn't restart it. October the 22nd, you can see that her wound actually showed that she was doing really well. And then she actually went on to close very nicely. And if you take a look at this, 13 weeks from the start of PICO to closure. So 13 weeks, we had a significant wound, and now we had closure. We used 5 weeks with PICO. So pretty big success. Here's just kind of showing how you can use strip paste to maintain your seal. And final thoughts. Okay, so PICO can be used on a variety of wounds eligible for negative pressure. And in recent study demonstrated the superior lower extremity ulcer closure rates compared to traditional. And I think this is really important to know that you have the research backing you up using PICO on venous leg ulcers, any of your lower leg ulcers, your diabetic feet. Statistically, you get better results. As long as your wound could fit underneath your dressing and manage your drainage, you get better results using your PICO, not to mention that it's got a better cost effectiveness with it. PICO unique mode of action delivers therapy to the wound margins and the peri-wound where you don't get with your traditional, extending the benefits of negative pressure right out underneath to the whole entire border. So I am happy to say that I've left some time for questions. So I'm hoping that we have some questions in the question box.
We definitely do. Well, first of all, thank you so much, Amanda. I think these were fantastic cases that you showed us here, and I traveled across a couple different areas too, including our ostomy realm there, which was fantastic. So I'm going to start us off with, I know we're going way back earlier into your presentation here, but there were a couple people who were asking about what gel sheet was used for pre-wound areas. And what are the names that, what's the official name of that there? I think we had a response in the Q&A box, but could you just touch on that?
Yeah, so it's the Renaissance gel patch. Leo, you can correct me if I'm not saying it right. It's actually called the Renaissance gel patch.
Yeah.
I did actually kind of show a picture of what it looked like. So it's a gel sheet. It's sticky on both sides and it has kind of the plastic on both sides of it. Make sure you peel both sides off. I did show that picture where I left the actual Renaissance there so you could actually kind of see what it looks like. And normally, when you're putting that on, just a tip application, I peel one side off, I stick it to the person's skin, then I peel the other side off because it's very sticky and it will stick to your gloves. So that's actually what I would use for creases. And you can also use it to help adhesion as well.
Amazing. Well, thank you for touching on that. I know it's in the Q&A box there too. So if anyone, again, just a quick reminder, if you have any questions before we finish up today, definitely still pop those in there. We can get to them before we end the session today. Another question that came in from a couple different people, and it's talking about the use of white versus black foams with PICO for tunneling wounds. Are they both suitable for wounds? How would you address the use of one or the other for tunneling wounds?
Yeah. So your black foam is less dense foam. So the difference between your white foam or you saw that I used the hydrophora foam, that type of foam, that is the same type of foam as what typically is your white foam. It's the same brand, or the kind of the same foam consistency. So that is a denser foam. And where I would use that denser foam is for narrower tunnels. So I would use the white foam for the narrower tunnels, where I thought there was any risk of the black foam breaking apart. So if I have to cut that black foam really kind of narrow to address a tunnel, then I won't use it because the black foam can break apart. And like I said, you do not want to leave any pieces behind. So you can use the white foam for narrow tunnels. I also use the white foam, a denser foam, if I'm finding the patient is having a real big problems with kind of trauma when you're taking that black foam off. So and I'm not saying that that's not a bad thing sometimes, but if it's causing trauma, a lot of pain, and the person isn't reacting too well with it, and my lady that I did use it, pyoderma, I don't want to cause trauma to the wound, so that's why I would use the denser white foam. Or you could also use an interface, such as like an Acticoat in there, to prevent that black foam kind of grabbing in and the granular tissue growing up into the black foam. Which can cause some trauma to the wound bed. Sometimes that's actually not a bad thing, but other times you may not want that. And that's why you would switch to the white foam or an interface in between that and your black foam. You don't want to you want to think twice about using black foam over tendon, bone, that type of thing. Not that it can't be done, but just you want to be cautious about that too.
Well, thank you for touching on that. And I know we're seeing so many thank yous in the chat here. So again, everyone's really appreciating how much detail you've gone into today and the great case studies as well. We have a couple more questions. One of them is talking about the use of peri-wound applications like the gel sheets you mentioned there. They're wondering if this impacts the effectiveness of PICO's negative pressure wound therapy compared to traditional negative pressure wound therapy.
Yeah, so good question, great question. I want to be really clear is that typically you do not want to put stuff around your peri wound. You do not typically want to put like your drape around your wound or the gel sheets around your wound. I use a gel sheet, so typically I use that for creases, so I maintain my seal. I did use it on that one lady, and that was actually just to kind of make sure that that negative pressure didn't slide off. But typically you do not want to use, and I'm glad this was brought up, you do not want to use things underneath the peri wound on the skin. You want the PICO dressing to come in contact with the wound bed and the peri wound, and you don't want an interface in there that will prevent that pressure from acting on the peri wound. So don't use drapes, don't use thin hydrocolloids, only if you need to maintain that seal, and or sometimes if you're trying to get a little bit better adhesion, because that one case she was shearing off her dressing, but that's not something typically that I would do.
Okay, well,
Because
thank you for
you want that, yeah, you want that actually to act, and that's one of the benefits of using the PICO is it acts onto the peri wound, not just the wound bed.
Fantastic. And we had a couple other questions here come in, still a similar kind of topic here, but this one specifically for someone who's talking about wounds under the feet. Have you seen any kind of contraindications of using negative pressure wound therapy for wounds under feet where you see hypergranulation happening? Have you seen any sort of issues with that?
No, so typically hypergranulation, you got to think about what the reason for the hypergranulation is. So hypergranulation sometimes is if you're not managing your moisture, you have a bacterial imbalance. Those are some of the things you got to think about. Why are you getting your hypergranulation happening? I don't think that there's a link between negative pressure and hypergranulation, because typically that's one of the perks of negative pressure is that manages your drainage and your bacterial balance so that you don't get that pooling of fluid. And sometimes that's what causes your hypergranulation. You don't typically get that with negative pressure. So I'd say it's actually prevents you from getting that hypergranulation, which you often see when you're not using negative pressure, because it doesn't draw away your drainage. It kind of lets it sit there. And typically that's a lot where you get too much moisture.
Fantastic. And I know only got about a minute left, but I think we can get through the next two questions, hopefully fairly efficiently here. And again, thank you to those behind the scenes who've been helping answer some of those questions in the Q&A box. We definitely appreciate it. There are a few people who are asking about what is sort of compatible under a PICO dressing and whether, paste or powders interfere with absorption in reference to, the Promegran, Acticoat, or Iodosorb. What do you think are compatible? What work best when you're using a PICO dressing?
Okay, so if you want to go like, I use off-label. So if you want to go strictly with what Smith+Nephew is going to say, you read their IFU, what can be used underneath the PICO is your Acticoat, your black foam, and your AMD Curlex. So those are the typical things that are used underneath the PICO. Now, if you look at disposable negative pressure in general, and some other companies, they will use hydrofibers under theirs. So anything, this is my personal view, anything that allows that moisture to wick up into the dressing so that you're not blocking the wicking and the negative pressure action. So that's when you need something that will allow the drainage to flow from the wound bed up into the dressing and out the top of the dressing. So you can typically use those types of contact layers. The ones that allow fluid to move through the easiest are all of your mesh types of dressing. If you're using a dusting of, a powder, that's not going to affect anything. So and when I use something like your collagenase dressings and stuff like that, those dissolve into it. So those don't affect it either. So I would just say, as long as when you're thinking about it, that you feel that it's not going to affect your negative pressure. So don't use anything, multiple layers of things that don't allow the fluid to move through isn't a good idea. So you want the fluid to be able to move through and not pool at that wound site. That's what you're going to really want to think about when you're thinking about your contact layers.
Well, thank you for touching on that. I know it was a big conversation that was kind of happening on the chat and the Q&A box there. And I know we're getting to the end of time here. So before I thank you, I just want to remind people who were asking about anything related to pricing or any specific questions for Smith+Nephew. Again, there is going to be a survey that's going to pop up at the end of the webinar here in your browser. You'll also get that as a part of your post-webinar email. You'll see that survey pop up there. That's one way of getting in touch with Smith+Nephew, and I'm sure they'll be happy to talk to you about that. Again, as we're getting to the end of time, I just want to thank you again, Amanda. I'm just echoing everything we've seen in the chat here, all positive comments. We really appreciate you sharing your time and your expertise. It's been so awesome being able to talk to you about this, and I'm sure it won't be the last time we'll have a chance to talk with you. So again, thank you so much, and thank you to Smith+Nephew for making this education possible today. We hope to see you all in the future. And again, we will have some more webinars coming up after our national conference. This is the last one before our national conference, which will be taking place at the May 1st to 5th. We will be coming back for a series of more webinars after the fact later on in May and into June as well. So thanks again, Amanda. We really appreciate it.
Thanks very much, Troy.
Have a great night, everybody.